down there, 3-3-2 rule. I have, every time that I've had an airway where one of those is not met, I have had some difficulty. Either had to go to plan B or had to change blade or something made it very difficult.
The M of lemon, malapati. You've all heard of malapati class 1, 2, 3, and 4. What do those mean? You know, it's funny, Rusty and I, when we were working on this presentation, you know, we bounced a lot of ideas back and forth, and it became very evident to me that we are very much aligned on a lot of things. The 3-3-2, I use it on every single airway that I put in. Malapati, we both essentially said the same thing. We know the malapati score of every person we've ever spoken to, because it's just one of those natural things that we do now. We look at every single person's malapati. So what does that mean? You look at the malapati, class 1. It's someone who, when they're talking to you and they open their mouth, you can see the soft tissue, the soft palate, you can see the entire uvula, you can see the posterior oropharynx. Class 2, you can still see the posterior oropharynx, you can see the soft palate, and you can see most of the uvula. Class 3, these are people who the uvula is pretty much obstructed. You still can see some posterior oropharynx, and you do see the soft palate. And then finally, class 4, all you're really seeing is the soft palate. No uvula, no posterior oropharynx.
So rods, once again, this is for the extraglottic airway. So you're putting in something like a king or an iGel or something of that nature, ridiculous issue. Restricted mouth opening, right? To people with small mouths. Any kind of obstruction, once again, you're going to have a problem. And also, it says distorted airway. So if you look at this as extraglottic airways, if you think there's something down there, so the anatomy is contorted for some reason, and so the airway may not sit appropriately, that is a contraindication for using an extraglottic airway. Obviously, some kind of cervical spine issue, they're wearing a halo, anything of that nature would make using an extraglottic airway probably not a viable option.
And finally, difficult crux. My mnemonic is short. Surgery, hematoma, obesity, radiation, tumor. People who have had previous surgery, there's going to be a lot of scar tissue. Your anatomy may be off. Those people I anticipate having a difficult time writing. Patients who have hematomas or other things that cause their necks to be inflamed, or such as infection with blood-loose angina. Obesity, the people with very short, fat necks where I cannot feel the anatomy, I cannot visualize the anatomy. Radiation and tumor. Again, scar tissue and or a large tumor that obstructs or moves the landmarks so that I'm unable to visualize or palpate.
So when you go to intubate, when you get ready to intubate someone, you've got to prepare your workspace. You should not have to intubate that rapidly that you can't set anything up. At that point, if you're not setting your workspace up, if anything happens out of the ordinary, which you anticipate happening, it's going to fail. You're going to fail. So you've got to have some idea of how to set this up. And you do it in training. You have suction. I've already said it multiple times. You've got to have suction available. It has to work. Oxygen, obviously, we're managing an airway. It's something we've got to give them oxygen. Airway equipment. Do you have the stuff you need to include some type of alternative airway? Do you have the rescue device? Do you know where it's at? And do you know how to use it? I say that, it seems sort of simple, you should know your equipment, but how many times do we have something in our bag and we're like, oh yeah, that's the king airway, but you don't even know how many cc's go in. You have to do the thing. Can you do a needle prick or not? I've had paramedics say, yeah, I've been a paramedic for a long time, I'm not sure if we can do needle pricks or not. And that's sort of important to know those things if you can do that. Positioning is huge. Position the patient, meds and monitoring, which we'll talk about meds in a little bit, and ETCO2, right? Two things it serves. We can confirm one method of confirming the tube placement. Also, we can monitor, are they still perfusing? Are we maintaining appropriate perfusion during it?
If you look to your right, this is something that we have as a glossy for each of our flight crew members. And I will readily admit that we sniped this from someone else. Rusty and I were at the Air Medical Transport Conference a couple of years ago. I believe we were in Long Beach, California. And we were sitting at an airway lecture, and a flight program out of Denver actually showed us this, and so we took it and we made it our own. We're not going to go over the whole thing, but it's called Have My Airplane. And the idea behind it is an intubation checklist prior to intubating, so that my crew members know they are ready to perform that intubation. And in fact, Rusty has mandated that every one of our crew members, when intubating, not only utilize it, but document it within our documentation that it is being utilized, so that we know that our team is prepped and ready to intubate.
And we can give those, if you need those, you can obviously route them to us. We have no problem sharing this if we stole it from somebody else. And I say, utilize your resources. And outside, when you leave here to the STEM lab outside, we actually have one that's blown up. You want to look at it. If you have any questions about it, please feel free to ask us after the presentation.
Preparation from a pre-intubation perspective. Oxygenation, it is key. If and when you have the time, take the time to truly do an adequate job of pre-oxygenation. And that includes things such as apneic oxygenation. With apneic oxygenation, all we're doing is taking a nasal cannula, turning it on high flow, while we're either providing the patient with blowby or bagging. And in fact, studies have shown that in healthy adults with healthy lungs, this can give you up to 8 minutes during an intubation before they start becoming hypoxic. In moderately ill adults, up to 5 minutes, and obese adults, 2.7 minutes. Now that being said, if the person has intrinsic lung disease, it may not be as effective, but it's still worth a shot. And so I highly recommend that you provide patients with apneic oxygenation.
We've probably all seen the desaturation curve, the chart that's got the curved lines on it and stuff. So rather than boring with putting it in here, one interesting fact is if you have someone that has COPD or some illness of that nature, when they go over the cliff, they rapidly desaturate, and it becomes a problem. You may only have a minute or so of really good working time before you intubate them. And since I implemented this into my practice, I've seen those patients maintain their SATs for 4 or 5 minutes, which I mean is unheard of for especially a very chronic COPD type patient. And so it works dramatically. It's very good. So we can obviously sit here and talk for a long time about Miller versus Mac, and we all got our stories and this and that. So I'll take this time to tell my story of why I switched from Miller to Mac. So it's hard to believe, almost 10 years ago when we started at Baptist, one of the training that I had to do was go to with an anesthesiologist in Pensacola. So the guy basically said, hey, very nice guy. He said, I want you to go in this OR, intubate something, then I can tell you whatever you want to do. Just get the person intubated and we'll talk about it. Okay. So walk in the OR, we've all been there, right? You walk in, everybody's sort of staring at you like, hurry up, okay, he's going. So I stick a middle of the blade on there, shove this thing in an 80-something-year-old person's mouth, pull up, pull back, 2 of them, done. So I walk out, and you go, how do you think you guys did okay? Well, give yourself a grade, 0 to 100%. So I give myself an 88 because they're intubated. You go, well, if they weren't intubated, I'd give you a 0. He said, I give you a 60. And he goes, I'm being generous because I don't really know you. And I'm like, okay. He goes, now come on this room to show you why. He goes, I'm giving you a 60. And so he showed me the mechanics of intubating because I'd been a paramedic for a long time. In paramedic school back then, they said, hey, just shove this blade in, pull up, push back. You see this opening, shove the tube in there. That was pretty much the summation of our intubation training 20-some years ago. And so he showed me that using a Mac blade, the technique, I didn't really have to move my hand. Literally, as soon as I put it in the right way and barely put some pressure, I saw a lot of opening almost every time. It was very easy. I didn't have to muscle my way through it. So the point of that story is we can easily banter back and forth, but train with both. Don't say, well, I'll only use this or I'll only use that. Train with both and open up your options, see what works best for you.
Now that being said, the MAC is going to be better in certain circumstances. The Miller is going to be better in certain circumstances. MAC is going to be better in obese patients because with large floppy tongues. MACs are curved, and so the patients who are not RSI or who are not completely unresponsive, you're not going quite as deep, and so you don't induce quite as much of a gag. Millers are going to be better for smaller mouths because it's easier to insert, and also for big. My thoughts are big floppy epiglottises where you can lift them up. But ultimately, it is a preference. We all have our stories, and once again, Rusty and I are really, really aligned on our practice habits. I'm a MAC guy myself, but my story isn't nearly as intricate. Mine is just because my mentor when I was in medical school, who ended up guiding me to become an emergency medicine physician, he's now the chief medical officer of the university in New Orleans. His name is Peter W. And he told me, Jeff, I can intubate anybody with a MAC. And so I said, well, you know, if he can do it, I can do it. And so I'm a MAC guy because of it. Okay, so this is the one where everybody's sort of focused. You don't take anything away from this presentation.
this is what I want you to take away from it. And I think it's something, this would be something cool, you can actually laminate this, put it in your bag or whatever, but you've got to have a game plan. So if we're managing an emergent airway, especially if we're in an out-of-hospital environment, and if we're managing a building on fire or a bad car wreck, you've got to, in your mind, you've got to have a couple plans in your head, because we know one's not going to, usually, sometimes not going to work. So plan A is just our regular initial intubation strategy. Maybe we're going to do, DL first, and then go to video, something like that. We're going to change some, maybe blames or something, but our initial intubation strategy, that doesn't work. What's next? Rescue airway. The emergency plan is not RSI the person. And you hear that, let's go to RSI. If it didn't work initially, don't give them drugs to make it even worse, right? So we'll talk drugs in a minute, but paralyzing is not the answer. You can't get them intubated initially, and they have no gag. Rescue airways come in. What we can debate there's so many rescue airways out there, we can debate it for hours. But know whatever your protocols and your facility has, and make sure you know how to use it almost second nature. And then if those two things don't work, back to the basics. Bag the patient up. Give you a good example. How many people go to intubate someone, pop the bag valve mask off, and chunk it? Horrible practice.